Hi, this is Tara Saxic. I will be presenting on heme metabolism in lead poisoning. This is MSCI 530 at Liberty University and with Dr. Eric Rhodes. So the introduction, lead poisoning results in a disturbance of heme biosynthesis, the severity of which depends upon the severity and the duration of exposure. But as we go on with this presentation, we'll see that age can also play a factor in this. So although typically found in peripheral blood due to the ease of sampling, all cells contain essential heme proteins. And because of this, lead has a high affinity for the mitochondria, which can find its way into all cells. And we will, during this presentation, be able to view the results as a widespread impairment of cellular function. Epidemiology and etiology looks at children under the age of 6 from low-income homes, living in homes before 1978, and also immigrant children. Immigrant children, because they're coming from third world countries, has less regulations and most often mediocre health care, it might go undetected. And then kids living here in the United States, however, under the age of 6, don't have the greatest of hand washing techniques, as well as could be easily exposed by putting things in the mouth. But then also, when they come from low-income homes, they're more likely to live in older homes, and that is where lead-based paint can be found. When it comes to pregnant women and the elderly, past exposure is typically the key here because lead can be stored in the bone and teeth. And as the body can't detect the difference between calcium and lead, the lead absorption is increased in a diet with low calcium. So lead can also be released into the blood from bone during bone resorption, and that's why this is key with elderly and pregnant women because of the bone degradation over age and the period of being pregnant too. So as the bone resorption takes place, whether it's osteopenia, osteoporosis, lead can also be let out into the bloodstream circulation. Types and classifications: acute and chronic, organic and inorganic. You can see acute and chronic differentiates between the duration of exposure, whether it be an intense or low level, and then also organic and inorganic. The biggest difference here is that the organic has a lead-carbon bond, and the significance with that is that it makes it more toxic. It's able to be absorbed through the skin more readily, and then also across the blood-brain barrier. Signs and symptoms. Signs are an objective finding found on examination, while symptoms are subjective and reported by the patient. These can overlap from time to time, but as you can see, again, reiterating back from the beginning, because of how lead can be found in all tissues, the signs and symptoms are going to be very wide-ranging. Normal and abnormal biochemistry. For the normal biochemistry, we look at heme synthesis as a biochemical process that occurs primarily within the mitochondria, starting with the condensation of glycine and succinyl-CoA by the first rate limiting step utilizing 5-aminolevulinic acid synthase, which is ALAS, and this forms 5-aminolevulinic acid, ALA. This is followed by a series of steps in the cytoplasm, like the conversion of ALA to porphobilinogen, PBG, by ALA dehydratase, and that is ALAD. Formation of the linear tetrapole, which is also known as HMB, from our 4 PBG molecules. Cyclization of the linear tetrapole to produce uropyrophenogen 3, carboxylation of the uroporphyrinogen 3 to form coproporphyrinogen 3. When coproporphyrinogen 3 returns to the mitochondria, it is then followed by the oxidation of the coproporphyrinogen 3 into coproporphyrin. Further oxidation continues to the protoporphyrinogen 9, and finally oxidation of the protoporphyrinogen 9 to the protoporphyrin 9. This accumulates in the final step of incorporating ferrous iron into protoporphyrin 9 by the enzyme ferrocatalyase, and this will produce heme. The process involves multiple enzymatic reactions, with some steps occurring in the mitochondrial matrix and others in the cytosol of the cell. Now, that was the normal. So when we're looking at the abnormal with the introduction of lead, lead poisoning impairs the heme synthesis by deregulating enzymes in the biosynthetic pathway. Lead poisoning increases ALA synthase activity by inhibiting the downstream enzymes like ALAD, like ferrocatalyase, and also coproporphyrin oxidase. As it tries to compensate for its ability to process correctly, this leads to the buildup of ALA, and that will trigger a compensatory release of ALAS in heme synthesis. And that's just in an attempt to overcome the cessation of the heme synthesis pathway. And so because the reduction in heme synthesis, microcytic and also hypochromic anemia can develop. And this is because many enzymes and proteins, including the P450 cytochrome, which is a part of the mitochondrial electron transport chain, are reduced. Now, because that is reduced specifically, energy metabolism is also affected. Pathogenic features and genetic basis. The exact pathogenic pathophysiologic, should I say, mechanism of lead poisoning is not 100% clear. However, we do know that the effects are wide-ranging, like we have mentioned already. Lead competes with zinc and calcium, therefore it disrupts many everyday processes, such as inhibiting calcium uptake and disrupting mitochondrial function. It also interferes with neurotransmitter function at the presynaptic nerve terminal that requires calcium. It also inhibits the calcium-dependent protein kinase C. Now, this is essential to brain function. So it also inhibits enzymes in the heme process by lead competing with zinc in the heme synthesis process. Now, the genetic basis, I was surprised to find that there actually is one. It goes with genetic polymorphisms affecting genes like the ALAD and also the vitamin D receptor. These can affect how lead is processed, absorbed, and distributed in the body, but it also affects how it is efficiently eliminated. Laboratory features. Lead toxicity causes hypochromic microcytic anemia. And we can see that the basophilic stippling of red blood cells there in the slide. Now, these hypochromia and microcytosis are typically seen in iron deficiency anemias, which coexist with lead toxicity. Assessing iron storage status, ferritin, in all cases of lead poisoning is important. In pregnant women, some evidence suggests that lead also causes a decrease in erythropoietin production and a depression in red blood cell production. Lead is a surface-acting poison and may produce increased RBC fragility and acute hemolytic anemia. And so you can see in the smear, under a microscope smear of blood of the basophilic stippling and of the RBCs in the hemolytic anemia right there on the left-hand side. Now, as noted, changes in the RBCs take place. We have elevated uric acid, which lead primarily damages the kidneys, specifically in the proximal tubules, which is responsible for filtering and excreting the uric acid. There's also elevated levels of FEP, which is where lead interferes with the enzymes involved in the heme synthesis, and that causes the accumulation of the protoporphyrin, which is measured as an FEP. The zinc protoporphyrin. ZPP is also where the lead interferes with the normal process of heme synthesis in the red blood cells. This will prevent iron from properly integrating into the heme molecule, and then it causes an accumulation of zinc, protoporphyrin, and then we'll also, of course, see elevated levels of lead. Differential diagnosis. So once again, because this is so wide-ranging with symptoms, we're going to have symptoms coming up from just about everywhere. So we can start with gastrointestinal symptoms, and that could range from cramping with abdominal pain to constipation, even things like peptic ulcers and irritable bowel syndrome. Neurologic conditions would be irritability or something as simple as headaches and fatigue, and also confusion. Hematological, we would see the stippling on the blood smear, of course, as mentioned. Developmental concerns would be learning difficulties and delayed development. For example, skipping down to vitamin deficiencies such as B12 or folate can also cause anemia, as we learned in our last section in class. And psychological disorders, things like depression, anxiety, ADHD, again, something that could overlap with different B vitamin deficiencies. Management and treatment consists of 3 different things, and it really depends on age and the significant severity of the lead poisoning itself. But a full bowel irrigation is typical, with or without chelation therapy, which would be an IV that extracts and kind of binds the heavy metal, and then it can be naturally excreted. And then, of course, everybody should be removed from the source of the lead exposure. Complications and prognosis. Exposure to a very high level of lead can severely damage the brain and the central nervous system, and this is predominantly in children, and that is one thing that is irreversible. So lead poisoning can be very, very severe. Patients who survive can be left with permanent intellectual disabilities and also behavior disorders. So the prognosis of lead poisoning depends on the level of exposure, age, but also body system that's affected. Children are more likely to experience long-term serious effects. Lead poisoning can not be reversed. However, the blood levels can be lowered, and of course, like mentioned, we can teach prevention from further exposure too. Current features is really they're trying to identify more sources. As I've mentioned earlier, some surprising ones have popped up. Also developing better detection methods, and then also exploring potential treatments. And the references are here. Thank you so much. Enjoy the rest of your week. Take care.